So the big takeaway of this study is we briefly alluded to this before, is RECIST the best way to measure these tumors or not? And the conclusion from this is it's not, and that T2-weighted signal, T2-weighted imaging on MRI, as well as tumor volume, may be a much more sensitive way to know that tumors are ultimately going to respond. And the key thing is that these responses are happening much, much earlier than when we see dimensional responses in RECIST. So this is data from the phase 2 prospective study of the Ringside study from Immunome. So so this is the study design. As you can see on the left-hand side, we have the phase 2. This is 42 patients. Patients were randomized through 3 different arms. One of the arms, patients got drug continuously. The other one was a different dose that was intermittent. And at the completion of phase 2, the continuous dosing of varegacestat at 1.2 milligrams once daily was picked, which is now part of the phase 3 randomized placebo-controlled study. So this study is closed. We're waiting for the final data to mature, and then we'll see. So what I'm going to be presenting is just on the left-hand side, the phase 2 portion of 42 patients, and primarily focusing on the imaging on this disease. One of the key things is I just wanted to remind this audience who may not be familiar is that varegacestat is also a gamma secretase inhibitor, similar to nirogacestat in that it's in the same class of molecule. So in terms of the analysis itself, patients were looked at screening, and then again 4 months later at week 16, and then every 3 months afterwards in these images. There were a total of 25 responses were observed, of which 1 was a unconfirmed PR. And the analysis also looks at the exposure and response modeling evaluated during the course of this study, both in terms of the drug effect on tumor volume, particularly in selecting for the 1.2 milligram once daily course. So this is the general patient disposition and demographics. There was 42 patients who were enrolled, and of those patients, 29 of 42, or 69%, entered into the open label evaluation once the phase 2 completed. The median time on treatment for this group is about 2 years, and there are 12 participants, about 30% of the phase 2, who are still on treatment. One of the key things to focus here is the tumor volume. As you can see, it's 46 cubic centimeter, but there's a huge range going anywhere as small as 1.4 and going up as 245. And then these are patients who had prior treatments, systemic surgery, and 1 patient even with radiation. And then the tumor location itself is both intra-abdominal, 35%, and extra-abdominal in 65% of patients. And this is just looking at the 1.2 milligram dose, which is the dose that is currently in the phase 3 study. And so there are 3 figures here. The first one is the RECIST waterfall plot. This is on the left-hand side, sum of diameters. And if you look at the 1.2 milligram daily dose, there is a 52% partial response seen, including 2 patients with a complete response at this dose. And if you look at all the doses, both intermittent as well as continuous, the partial response as well as complete response combined is minus 48%. So quite an impressive waterfall plot. But some of the areas to focus here are really sort of in the waterfall plot, not just look at the blue and the green, but those that are in the yellow, which we would call as stable disease. So these are patients whose tumors at their best response never quite achieved a minus 30% response. So it's worthwhile to sort of really focus in on these handful of patients and see really what's happening. The next looking at would be the T2 signal intensity. So for those who are not in radiology, the T2 really is an MRI terminology that looks at the weightage. it weights the water content in the tumor itself. So shifts in T2, in other words, if a desmoid tumor is very cellular, it'll have a high T2 signal. And if it shifts towards more of a collagen-based, then the T2 drops. And what we're seeing here is that change in T2 signal from baseline all the way to the very best treatment. And that's what this T2-weighted signal intensity shows. And what you're seeing here is that the vast majority of patients, have this shift from a cellular desmoid to a collagenous desmoid, which we think of it as a treatment response where these patients have achieved, for lack of a better, where the bulk of their disease has really resolved from a cellular active disease to a collagenous mass. So particularly pay attention to those who are in the yellow. These are the same patients by RECIST criteria who are said that they just had a stable disease or they didn't really have a response. But if you looked at those same tumors using T2-weighted signal criteria, even those who have stable disease by RECIST are having a response if you look at T2-weighted signal. The same thing with tumor volume as well. These tumors are very complex. They go through multiple different fascia and plane. So just looking at it at one single dimension, as RECIST does, is really not the most optimal way of looking at it. And when you look at the dose that was selected for the phase 3 study, 88% of patients have at least a 50% response in tumor volume. And the T2-weighted signal is 95% of patients have a change in tumor volume. And this is a very intriguing slide. So on the far left, you're seeing sum of diameters, which is back to RECIST. We're just looking at the dimensions of the tumor. And you can see that at two different doses are prescribed here. One is the blue one, which is the dose that is now going forward, which is the continuous dosing. And you're seeing that these tumors are shrinking with time. But if you look at the T2-weighted signal, what you're seeing is that the T2 changes are happening much, much earlier than just looking at RECIST itself. So going back to a point that was raised earlier is that a patient says, I'm still not responding. How long should I be on the study? And here you can have a biomarker looking at MRI signal and saying, yeah, your tumor may not be shrinking, but we're seeing things inside that are already shifting that signals that you're already getting a disease response, and similarly volume. So both T2-weighted signal as well as tumor volume are early biomarkers that predict for an ultimate sort of tumor shrinkage as per RECIST. So these are more sensitive radiologic imaging markers here. So this is a swimmer plot that essentially says that patients who are responding continue to respond at many of these doses. And in terms of exposure response analysis, on the x-axis, this is time since the first dose. This is in months. And in the y-axis, you're saying change in tumor volume. And three different doses are described here. One is the 1.2 milligram, which is in the blue line, and then the 4 milligram and the 2 milligram. And what we're seeing here is that the 1.2 milligram, which is daily dosing of the gamma secretase inhibitor, induces a very nice and sustained improvement in tumor volume compared to even some of the intermittent dosings. Similarly, the median percent change in patients with a complete response and partial response, as well as stable disease. So patients who had a complete response, a partial response, they are lumped together, and those with stable disease are analyzed separately. And again, what we see is that even though the degree of change in T2 is not as profound as those whom you see with a partial response or complete response, that even those patients with stable disease are having very profound changes in their T2 signal as well as in their tumor volume as well. And again, this shows that three different sort of analysis. Essentially, the first one on the x-axis, we have change in sum of diameters. On the y-axis, T2 signal, and there is a there is a correlation that shows that these two things really go hand in hand in terms of tumor volume and RECIST responses as well. So in conclusions, essentially what we're showing here in this data set from Immunome's Ringside phase 2 study, the phase 2 portion of the phase 3, is that we start seeing these early and rapid reductions in T2-weighted signal on MRIs, and these may predict for a RECIST response in the coming months. And there is a growing body of evidence to show that not only this may be the case with gamma secretase inhibitors, but potentially also with other drugs such as sorafenib. And lastly, there's exploratory exposure response modeling that suggests that the 1.2 milligram dose, which is the one that has now been picked and completed for the phase 3, achieves earlier and deeper response than the other dose regimens. Thank you for your attention. Happy to take any questions.
From the response definition, is there a way to correlate the T2 data with the PROs from patients where they tell us in the first week, as you heard this morning, hey, I went on this medication and my pain's gone or my pain's substantially improved? Because that would also strengthen your argument for taking RECIST to the dumpster and trying to replace it with some other things.
100%. We don't have the data yet, but the Immunome group is shaking their head because they're looking at that very critically. But again and again, the key thing is, so what if your tumor responds? Like, who cares? At the end of the day, if you don't feel better, and if you're not moving better, if you're not sleeping better, like, what difference does any of this make? And so I think ultimately we need to link radiographic imaging to patient-reported outcomes. And that is complex, but I think we need to triangulate RECIST, T2, as well as PRO, and try to see what are these thresholds. These thresholds that are picked, RECIST minus 30% is a made-up number, right? Somebody said, we're just going to pick 30% out of a hat. Same way, T2-weighted signal. Like, what is the threshold? Nobody knows. It's a number that we all have to, we can basically pick up here is minus 50%, minus 30, minus 70, you make it up, and similarly with volume as well. But I think what is the gold standard is patient-reported outcomes. How do patients feel? We can, I think, benchmark everything to PRO, and we can come back and say, maybe even for RECIST, you don't need minus 30%, maybe 20% correlates to improvement in function. And that could be like, sort of a modified imaging criteria in this disease.
And actually, one follow-up question, I'm sorry, too. Because the data you presented on the stable disease, the differences you were seeing, I think, interestingly, for the people who had stable disease but were not responding, whose tumors were getting larger, that would serve, could the T2 signal be used to help guide biopsies to those areas to get maybe data earlier on why people are resistant and know faster that this medicine's not going to work?
No, that's a great, yes, I agree. Yeah, absolutely.
Thank you. I'm wondering if any other kind of imaging, almost like a radiomics, could be applied to assess not just the overall T2 decrease, but the patterns. Is there a decrease in around the periphery? Is it distributed elsewhere? Do we see sort of a popcorn appearance?
Yeah, Yusuf Masahari and a couple of other people have been working on it in terms of looking at texture and also looking at a single box cell rather than, because, these tumors, they are not uniform, right? I mean, you see these patches of cellularity, and how do you measure that, and what do you compare it to? It's not straightforward.
No, it's not at all straightforward. And I think I mean, when we do this kind of analysis, of course, we measure to adjacent muscle, but even then you've got to be careful because you could have regions of necrosis within that tumor that are very T2 intense, and it'll throw you off.
Absolutely.
Yeah.
I agree. Yeah.
I have a question. How's the T2 signal gated, like scan to scan? Because as soon as these data started emerging using T2 signal, I've like started paying attention to it in my patients in clinic. And as you were presenting, I started to wonder if the images I'm looking at are gated differently, and am I like making bad conclusions if I see the signal go down or stay the same? Could it just be that the way that it was gated is different? And how is that controlled for in this study if that is an issue?
Yeah. So the bottom line is that T2 itself is a unitless number. You know, unlike CT, where you can get a density and you can get a number for the density, T2 itself has no unit, right? So the question is, what are you comparing that to? And the answer is adjacent muscle, right? So the way these things get measured is you look at adjacent muscle, and then you say, well, what is the density of this in comparison? And you use that adjacent muscle throughout all your imaging. In clinic, you know, I usually reach out to the radiologist and say, can you comment on the T2? Not everybody does it. I would say 90% of the time, people don't comment on it. So I reach out to the radiologist, can you please tell me what's happening with the T2 signal? Is it changing or not? And the complexity, sometimes the volume of the tumor is also shrinking. So the proportionality of T2 within that volume may increase or decrease as well. So yeah, I mean, I usually I've been focusing a lot on T2 and not so much on the size itself. And I tell patients, I said, yeah, you know, you're not seeing much shrinkage. Maybe you just have a 5% shrinkage, but the inside the tumor is starting to shift. Things are moving from a cellular to a collagenous form. And then the radiologist, I try to have them either addend a note or something to say that there has been some change in T2. But it's labor intensive, right? And a lot of radiologists don't do that routinely at all.
Thank you.
Okay, thank you.